So it's a burden of cleft care in our country. As you know, Ethiopia is a large country with a population of 117 million, and only 28% of the births were attended by professionals. There is no national data on the extent of birth defects, and there is no community-based study on the incidence of clefts in our country. So, but it's known that an estimated 7.9% of total births worldwide are born with birth defects, and the vast majority are born in low and middle income countries. But since there is no birth defect registered in Ethiopia, the number of children born with birth defects is not exactly known. Well, cleft is known and commonest congenital anomaly. It's about 1 in 700 births. It varies depending on geographic and origin, racial and ethnic backgrounds. The incidence in Ethiopia is not known, but the study in Addis Ababa shows that it is high, 1.49. Again, I said no birth defect registry, and the experience of comprehensive cleft care in the country is very limited. There is only single cleft care center in Ethiopia for a population of 117 million people, which accommodates psychological support, feeding and surgery, speech therapy, and orthodontics. But there is no established nutritional program for cleft patients. And this center is also a training center for cleft and cleft-related surgeries, for speech therapy, for cleft orthodontics. It also involved in capacity building activities in cleft care in different hospitals. And professionals from different parts of the country are attending short-term training at our unit on a regular basis. So when we look into the burden of cleft, burden of care is highly relevant in the management of cleft patients because it demands multiple surgeries and interventions. And it needs long-term follow-up, like speech therapy, orthodontics, NT, psychological support, feeding, HC. All this needs long-term follow-up, repeated visit to the centers. So it has a burden. As you all know, any surgical intervention is a major event for patients and families. And this includes cost of the surgical procedure. In fact, we are lucky we have the support of Smile Train, and cost of travel, that also we have the support, but in relation to that, leaving a family member and traveling a long distance to travel to a bigger town is really a hassle, it's a burden. And leaving some family members behind is also a huge burden for the families and for the patients. And the burden of cleft care in Ethiopia is not studied, but a review done by me showed that only 3% of the patients who are received surgical treatment fully rehabilitated. And this could be because of the burden, because of lack of knowledge, it could be because of the need for long-term follow-up, because of the distance. And Awayele in Nigeria had a similar experience. We have successful collaboration with Smile Train. Now we are collaborating for 14 years. At our unit, for example, we did more than 2,000 surgeries. We did researches. We trained professionals. If you consider the whole country, we operated more than 30,000 surgeries with the support of Smile Train. We did multiple researches. We hosted PACLIP 2 times. We are competing with the Nigerians. Nigerians also hosted 2 times. And we received multiple donations, including supplies and related with COVID. We also collaborate with Transforming Faces, similarly for the last 14 years, support comprehensive cleft care, research, training, training specifically speech therapy, and also receive donations. We also collaborate with Project caren Ethiopia for provision of safe patient travel, community speech therapy, and we are collaborating with PACT It's a Partners in Africa in Cleft Training. This is a collaborative effort between Kumasi, Ghana, Nigeria, Maiduguri, Seattle Children, and my unit. And we did training for professionals at my unit in the country and in other parts of Africa. And we also received donation. We also collaborate with Toronto Addis Ababa academic collaboration in training speech therapists. We also collaborate Iowa University through Professor Butali. Through that collaboration, we collaborated with Nigeria CRAN, as Professor mentioned earlier, and Ghanaian craniofacial anomalies, through which we did multiple publications. And we are also actually created a friendship, very nice one. And we hope this collaboration will continue in the years to come. And when we see the challenges, Olasoji et al. Reviewed some of the challenges of cleft care in Africa. They reviewed published articles from 1965 to 2006. And their findings was that they found no reliable data on clefts in the reviewed articles. They found strong traditional belief system exists regarding etiology of cleft. For example, they are related with scars with different local traditional beliefs. And patients with cleft commonly present late when the golden time for speech, for having intelligible speech is also passed. Some have advanced complication. And they found that there is lack of multiple approach to care. And they concluded that the chance that a child born with cleft tomorrow in Africa will receive the best care possible cannot yet be guaranteed. And they also urged the need to formulate basic strategies to improve the standard of cleft care in Africa, and the rest of the developing world is overdue. So all the challenges discussed by Olasoji et al. Are still existing in our country, and I'm sure they exist also in other countries. In addition, our country is huge. There is also financial constraints. There is lack of infrastructure which provides comprehensive cleft care to the community. There is obviously lack of knowledge and lack of trained personnel. And there is no government cleft care program. Our cleft care program is completely dependent on charity organization. And currently the issue of COVID is a huge problem. And it is not also, cleft care is not also a priority for the government. There are other health issues, infectious issues, and other issues also. So what is the way forward? The way forward is to involve the government in each country in their country's cleft care program. And this could be done or initiated through identification of stakeholders like Ministry of Health, Ministry of Education, societies. It could be plastic and reconstructive societies, maxillofacial surgeon societies, maybe pediatric societies. And also the charity organization which supports cleft should collaborate. And it should be initiated and step-by-step increase the role of government in cleft care. Which should be support, Smile Train should support the establishment of new cleft care centers. And it is also very important to bring the service near to the community. And we should support community-based researches, strengthen international collaboration, involves the health sector of African Union in cleft care, because African Union is left behind in cleft care, I think. In 2009, when we did the Pagli conference, we invited African Union and the province to be involved. But after that, there is no much involvement, and we have not also approached them. So we should involve them. And we should involve the Pan-African Cleft Lip and Palate Association. And I think we should involve more hospitals and surgeons with appropriate training in cleft care. Thank you very much.
I would like to thank members of the panel, especially our moderators, Professor Adeyemo and Professor Bankole. Thank you for streamlining also the content to participate. It was much clearer, as Professor Hachete has appreciated. And so I'm going to just give a brief point of view from our angle in terms of the role of government in the sustainability of comprehensive cleft care. Personally, I would like to start by a big thank you so far for what our governments are doing, especially my government here, in facilitating present actors who are involved in cleft care. I think we have had very little interference and blockage. We have had the government support to be able to run cleft camps, to be able to organize the cleft-related activities outside the government circles or public health system. So it's a big thank you. It's a big win. Creation of cleft care societies is facilitated, and there is ongoing cooperation right now with NGOs that work in cleft care. And so it's a big thank you for this open door that the governments have given us so far to be able to take care of orofacial cleft patients. My presentation will be from my local experience, and I would start with this recommendation that is over 10 years old, that the awareness that came out from the 8th plenary meeting of the General Assembly of the WHO. And when they had the report on birth defects, they were deeply concerned that birth defects were not still recognized as priorities in public health. And they were concerned by the limited resources dedicated to prevention and management of birth defects before and after birth, in particular in middle and low income countries. And this was one of the resolutions, was to raise awareness among all relevant stakeholders, including government officials, health professionals, civil society, and the public, about the importance of birth defects as a cause of morbidity and mortality. And we are all aware of the impact that orofacial abnormalities do to our society in terms of morbidity and mortality, especially childhood mortality, because of its congenital nature. So this was a big start. This was a big initiative at a very big level, at a very high level of our health structure. And it's, however, saddening to see that there's been very little follow-up. And I suspect that most of us will share same experiences in terms of where we are at since this resolution was made. There are many other resolutions that are in the paper that is cited here on this slide. This is my hospital, and my hospital for the past 5 to 6 years has concentrated itself to run a cleft orofacial cleft program with a determination to be consistent, to be persistent, to push through the hurdles and the difficulties that we all encounter. And so I'd like to share just some nuggets from this slide. The first one on your left, I think on your screen, shows the numbers from 2016 to 2021. And so we are at about 401 submitted and approved cases, and so this is the official. It's much more, but this is the official figure that we show. So it's been progressive, and if this is an indication of what other cleft centers and hospitals are doing in their regular outreach or operation programs, I think we are making progress and we are headed in the first direction. 2020, 2021, obviously, were not normal years, as we know, because of the pandemic. The next diagram here shows the proportion of secondary to primary cases. And what I would like to say for this one is that, as you can see, the primary cases outnumber secondary cases. This might sound like a very good thing, but really, for me and for us as a team, it shows us that we are lagging behind. We are lagging behind because in cleft care, we know that most of us on this panel are surgeons. We know that the first attempt is usually not the final. There needs to be retouches, and we need to come back to correct things. And so if the correction part is not large and the primary part is larger, it means we are still playing catch up. And the last one on your right, bottom right, is really interesting because it's the median age of our experience of when these clefts are done. We know this is a congenital abnormality, but we see them as Professor Ashete has said, they present late. But what we are seeing here is 24 or 25 months. And this is when speech is beginning to form. Again, this is late. This is late in terms of desired results of reducing morbidity and mortality. So this needs to improve. We need to see them, we need to operate on them a little earlier than 24 months. Making a summary of this is what we call the backlog theory. You see, 90% of our cases are primary and early clefts. But there's a 10% in our series. There's a 10% of people that show up at an earlier age. This calculation is actually 18 years and above. We have a 10% of patients in our series that were seen after 18 years of age. Again, if we still have people that grow into adulthood that are more than 3 years, in my opinion, it does mean that we have a big bulk of clefts out there that we need to catch up on. And so we have this backlog that we have to clear. So the burden, to summarize, it's the burden of cleft care in our country. If it can be deducted from this experience, is very, very huge and very large. And I think we concur and we share the same experience with Professor Ashete from Ethiopia. So we need to clear the backlog, and it is not a good thing. And we need to operate on them much earlier if we have to achieve our goals of good speech and good mental development and good insertion in the society. So we need to aim at earlier than 2 years. We might have better results, especially with speech and integration. So the burden is big. In our experience, we do have a small nutrition program that accompanies our efforts. So we try to integrate that with our national nutrition program in collaboration with Smile Train Help. And it's struggling, but it's growing. It's going to grow. It's an awareness raising issue in our colleagues in the nutrition department and pediatrics. We have run treat and train missions. We've been serving as a practice center especially for local surgeons who want to, who we are challenging to develop skills in cleft care. And so we have a number of surgeons, about 6 that have been trained. And we've been acting as a training center also for the WACS program that's running at our sister hospital in Dakar. We've been serving as a training and practice center because of the volume of what we do. Our challenges are big. Audiophony, language experts are scarce, and our challenges are similar, I think, with the rest of Africa, as Professor Ashete has highlighted in his wonderful presentation. So governments would help us to raise awareness among all relevant stakeholders, health professionals, civil society, and the public about the importance of birth defects, and in this case, especially orofacial cleft, as the cause of child morbidity and mortality. They could help us set priorities, commit resources, and develop plans and activities for integrating effective interventions that include comprehensive guidance, information, and awareness raising. To develop and strengthen registration and surveillance systems for birth defects within the framework of national health information systems, in order to have accurate information and available for taking decisions. When I was looking at the atlas of orofacial defects in the literature, I found that on the atlas that exists right now, the only African country represented is South Africa. I know that this is the atlas has not been updated in a long time, and maybe the situation has changed. But we need to see a different picture in terms of data available for research put out there. We need to develop expertise and to build capacity on the prevention, treatment, and the care of children with birth defects, and to facilitate societies to champion the cause. I can go on with this list of recommendations. Like I started with a thank you, and I know that most governments are involved in helping universities and societies, but I think there needs to be a deliberate approach, as we have other approaches in combating other public health issues. We need to, at our highest level, get the support that we need to facilitate sustained impact with the help of well-wishers like Smile Trend, for us to have a chance at continuing cleft care when donors pull back. We hope they don't. So I thank you for your attention, and thank you very much.
Merci, professeur Bankole. Par rapport à la prise en charge des fentes labiopalatines au Mali, j'avoue qu'avant les premières missions effectuées par des chirurgiens français en 2001, il n'y avait pas vraiment de prise en charge par rapport aux fentes labiopalatines. Il y avait des missions ponctuelles, par exemple, de chirurgiens du monde qui, au gré des missions dans les différentes régions du Mali, faisaient une prise en charge épisodique. Et moi, j'ai travaillé avec 2 associations. Une association française qui avait travaillé au Mali dans mon hôpital mère-enfant le Luxembourg entre 2001 et 2009. Et il y avait des missions qui étaient organisées par cette association. Et entre 2 missions, c'était à peu près le désert. Et donc, c'est ce qui a motivé une formation dans le sens de la prise en charge des fentes labiopalatines en France, dont j'ai pu bénéficier. Et nous avons maintenant implémenté le système au Mali. Nous avons accueilli ensuite la mission de Sourire d'Afrique des Canadiens, qui étaient des partenaires de Smile Train, et qui, à leur arrivée au Mali, ont eu à juger les différents types de chirurgie et ont décidé de faire de l'hôpital mère-enfant le partenaire de Smile Train. Pour parler des actions gouvernementales, malheureusement, à cause des problèmes que vous devinez par rapport à la sécurité, la prise en charge dans le domaine de l'humanitaire n'est pas parmi les priorités du gouvernement. Donc, s'il faut répondre à la question de savoir si Smile Train se retirait, par exemple, du Mali, qu'est-ce que la prise en charge de ces fentes deviendrait? Ce serait vraiment problématique parce que derrière, il n'y a pas une vraie assise pour faire bénéficier les patients de toutes les opportunités que Smile Train offre, à la fois pour la prise en charge nutritionnelle avant la chirurgie. Et nous n'en sommes pas encore à la prise en charge holistique pour la composante de l'orthodontie. Mais sinon, même le programme d'orthophonie aussi est assez timide, même s'il y a une formation d'un orthophoniste dans le temps. Donc, moi, je fais une présentation d'une situation qui reste précaire au Mali. Précaire à la fois à cause des problèmes d'insécurité, à cause d'une paupérisation due également à ces problèmes d'insécurité. Nous avons des zones du Mali où nous n'avons plus de droit de regard, en fait. Et nous ne savons même pas ce qui se passe parce qu'il y a des régions où l'État reste absent et donc nous n'avons pas de notification même des naissances en tant que telle. Donc, c'est une situation qui est décrite comme ça, paraît assez, sans jeu de mots, très noire. Et donc, mais c'est la réalité de mon pays en l'état actuel où nous ne pouvons pas nous permettre de dire qu'on peut se désengager vis-à-vis de Smile Train.
Merci beaucoup. Je ne sais pas si vous avez fini, professeur Traoré.
Je voulais faire une sorte d'échange direct si cela était possible, étant donné qu'il n'y avait pas une présentation en tant que telle. Donc, je ne sais pas si les questions viendront après au fur et à mesure, mais notre situation est beaucoup plus problématique que celle d'un pays où Smile Train est une organisation très solide entre plusieurs hôpitaux, etc. Et au Mali, je veux dire qu'aujourd'hui, j'ai une jeune collègue qui travaille au niveau de l'hôpital où j'étais et qui assure bien la prise en charge des fentes, mais nous restons très largement tributaires des contributions de Smile Train. Donc, voilà.
Merci beaucoup, professeur Traoré. Je pense que les questions vont venir après et vous allez pouvoir y répondre. Alors maintenant, je vais appeler, merci infiniment pour cet aperçu de la situation de la prise en charge des fentes labiopalatines au Mali. À présent, je vais appeler professeur Tambo, s'il est là. Tambo Moifo, est-ce qu'il est joignable?
Oui, oui, je suis là, patron.
Okay,
One moment, please. Professor Bankole, would you be so kind as to summarize Professor Traore's presentation? We are having a bit of a hitch with our French translator. You could possibly assist with a short summary.
Professor Traore said that there is a big burden of care of cleft lip in Mali. First, it is done by outreach, some cooperation with outside of the Mali come to operate the children. They begin only in 2023 to operate themselves for their children of cleft lip. What? You don't understand what I'm saying?
Continue.
Hello? Do you understand me?
Please continue. Yes, yes.
Yeah, okay. So Professor Traore says that is a big burden in Mali because of the war in the country. You cannot reach a lot of people, a lot of children and people with cleft. So they just began to, in 23, they began in 23. And now there is only surgeon. Speech therapy is not begun very well. They don't do orthodontic, so they cannot continue without the help of Smile Train. It's in summary what he said.
Thanks for giving me the floor in English. Thank you very much for giving me the opportunity to share my slide with the other member of the panel. I'm very happy to greet Professor Mekone, Professor Debola, and this big team of Smile Train. I'm going to talk about the whole of government. The slide. Okay. Okay. The exact prevalence and incidence is unknown in this country. We have few studies done, and in my hospital, we have many cases who has been operated for more than 10 years. We have a surgical team for outreach, and many cases have been operated during the outreach. The incidence seems higher in some region of our country. In the north and the far north of Cameroon, we have a high incidence of cleft. We don't know why. Maybe because they used to marry in the family. That is what we expect. But we need to make some study to know more. Next. Okay. What about the burden of care of cleft lip and palate in Cameroon? Unmet surgical burden of cleft care and underestimated. Patient-related consideration, ignorance about treatability of the condition, poverty limit presentation to the hospital, out-pocket payment for health care cost, parental apathy. The second point is hospital-related consideration. There is a lack of adequate infrastructure in most regions. Adequate health institutions exist only in big cities. Fully trained personnel for cleft and lip palate care. Lack of supplies. Next. Next.
Professor Bankole?
Yeah, we don't understand Professor Moifo. Professor Moifo?
Is muted.
On ne vous entend plus.
Is muted. Let me unmute him.
Okay. Do you want? I will. I can read his slide if you want.
Professor Mafo is muted.
Emily.
Can you unmute him?
Okay, he's not muted. He's muted on his end. On his end.
Oh, he muted.
Professor Mwako, yes, he needs to unmute himself.
So, can I?
Can you hear us? I think he's having trouble hearing us as well. Professor Mwako, are you able to hear us? Please unmute on your end.
Professor Mwafo.
OK. J'ai ouvert. Yes.
Alors, continue.
C'est bon.
Oui, continue.
C'est bon. OK. Est-ce qu'on peut me permettre de partager mon écran?
Emily, can he share his slide?
Yes, shortly.
We don't hear you.
Okay, do you hear me?
Well, we hear you now.
Yes, thank you very much. I apologize for, I say that from 2016, we are setting up a multidisciplinary Cleft team for surgical outreach, including those persons who are there. Next. And we have a training of local surgeon and paramedical personnel during Cleft mission. We have a seminar on comprehensive Cleft care organized in September 2021, and also 2 days nurse training course on comprehensive Cleft care held in 2017 and 2019. We have, according to Avenue for Collaboration, the aim of collaboration, setting up a sustainable Cleft care delivery program. We have the support of our ministry for this. Establishing a renowned center providing safe and quality Cleft care. We are discussing also with the Ministry of Public Health for this. The problem is we need a hospital who have the surgeon who can do it and also have a good theater. That is some problem we will face. The ideal model for collaboration, initially providing care through surgical mission with national of the same country, investing in capacity building, human resource and infrastructure, which time and increasing expertise for local team, progressive transition to autonomy. We have many surgeons who are able now to do cleft lip and palate surgery alone. So I think we are not so poor for this. The next, the collaborations. Look at this, the scientific impact. We need a better understanding of epidemiology of the cleft. In the north and the far north part of the country, we have more cleft. We don't know why. And we need to establish a patient database. We don't have it yet. The clinical impact, the decreased morbidity of cleft, even mortality, better assessment of long-term outcome. The challenge and gaps in administering comprehensive cleft care, patient-related challenge, ignorance about existing free cleft treatment. Some people don't know, but we are doing this for more than 10 years. Low threshold satisfaction with an aesthetic and functional outcome. Some surgeons who are not very well trained, they used to do surgery, but sometimes the result is not very correct. It's not the aesthetic is not good, and we need to go back to the theater. And we also the other challenge is non-compliance with follow-up schedule. We also have challenge related to hospital. Difficulties setting up cleft team. It's not easy. We need to be friends to do it. Not all specialists concerned are available in the same hospital. Sometimes I am in this hospital, the orthodontist is in another hospital, so it's not easy to have to plan to have the same consultation. And we also have various services do not exist in some tertiary hospitals, like orthophonists, speech therapists, orthodontists, and so on. We also face the lack of various equipment for surgery, feeding, dental, orthodontic, and speech rehabilitation. And we face all these challenges. The next, okay. Health system related challenge. No social cover for the high cost of care in hospital. The hospital provide, when we have a cooperation with Smartrin, and poor, this one is not a problem, but sometimes they don't have money to come to the hospital. So we need people who can carry them from the village, from the hospital, from the town. And poor or inexistent referral system, late available at appropriate centers. That's the congenital surgical condition children not included in funded child health program. Okay, so if you have a congenital health problem, if a cleft lip, sometimes we need to make an echography, and we don't have it. We don't know how to do it, and sometimes we cannot do it in the same hospital. We have to go someplace and have to pay. The policy partnership to build, yes, the Ministry of Public Health. Okay, that's the partner. Even the Faculty of Medicine and Biomedical Science of the University of Yaoundé, they support the existing pediatric surgery training program. Next, policy partnership with professionals providing cleft care. We assist in setting up the Cameroon Association of Cleft Lip and Palate. The CACLIP should be open next year, but you have a small problem. Some of my colleagues, like Dr. Ben and Dr. Eduma, was not in the camp at this period, so we postponed it. We have the parent and family. We can set up a parent and patient support group. This is an idea. We are discussing on it already with national and local media, educational campaign, media publicity on treatment center, share success stories. So that is what we already have. We don't have a national program for cleft lip and palate care, no. We are discussing with the Ministry of Public Health, to the first one who helped us. 10 years ago, we have Mission Souris d'Afrique coming from Canada with Professor Labège, who was in Yaoundé 2 times. And we also have some of associations like We Care Foundation, Mission Souris Sainte-Marie, who is not really working now, but we have a Clinique Sainte-Marie. We also have other foundations who have initiative, the religious organization, and some of the partners are in Douala or in Bamenda, in the northwest part of the country. And we need the support of the government. The Minister of Public Health is already, we already mentioned it to him. We have a meeting with him, and we are proposing to put this cleft lip and palate in the program of his ministry, and he agreed. I think we are going to have the support of the ministry for the next year. Thank you, and I expect it was not very easy. I know it was not easy because my connection was not good. Thank you very much for your attention.
Thank you, Professor Mwafo Tambo.
Thank you very much.
So now I give the floor to Professor Adeyemo.
Okay, thank you so much, very much, all the presenters, Professor Mekune Shete, Professor Fosin Tambo Mwafo, Dr. Adamsi Firi, and Professor Amadi Traore. Thank you so much, and I think we are able to have your presentation within the stipulated time. Now is the time for us to respond to questions. I'm aware that there are some questions on the chat forum, both written in English and also in French. Is that correct, Professor Bankole?
Yes, there is one in French.
Okay.
Mm-hmm.
So thank you so much. Emily, should we continue? Are we on course?
Yes, we are. Thank you so much. Let's proceed.
Okay, thank you so much. So there is I think it was Professor Isheti that in his presentation made mention of African Union, and one of our there is a question regarding that, and the question is there an African Union health sector, and how can the sector be accessed by by us. Professor Shitty, is there an AU health sector, and how can we access this sector, health sector in AU?
Can you hear me?
Yes, we can hear you clear.
Yeah, I really don't know how to, but I'm sure there is health sector. Now there is a East African wing. They are, I think, preparing to build a health, a big health care center here in Addis Ababa. I know that there is a health care sector, African Union sector for health. So I think Smile Train officials should explore, and actually, you know, Smile Train's activity should be visible, and should some sort of advocacy should be done. What is going on in Africa with the support of Smile Train, and how this is going to continue. I just thought maybe it is good to start from the top and go down. Start from AU, local governments, and like ministries, societies, because that way they will get some awareness what is going on, what's a cleft patient. You know, unfortunately, some of the officials, even health officials in my country, I don't think they know about cleft care activity. So I'm sure there is, but I don't know how to approach it. But Smile Train officials should reach to AU and find out.
Okay, thank you very much, Professor Shetty. What is also obvious about this presentation from all the panel discussants is the fact that in all the countries that you have in all the countries, majority of the countries in Africa, cleft care is majorly being provided by mission and also essentially by Smile Train. That's what I got from the discussion. It's either the Smile Train is well established in the country, or people come once in a while to come and have the surgery and go. But one thing about that of Smile Train is that Smile Train empowers local surgeons and other local cleft specialists, the orthodontists, the speech therapists, and so on and so forth. So the question is that Dr. Adams-Sifiri, this is for you, and also for you also, Professor Amadi Traore. If those who come around to do cleft in Africa, in your country, if they refuse to come, what do you think will happen to cleft care in your countries? Professor Amadi Traore first, then Dr. Adams-Sifiri next. You are muted. You are muted. Professor Amadi Traore is muted.
Oui, et là, vous m'entendez? C'est bon?
Oui, on vous entend.
Okay.
Très bien.
I can hear you now.
Et donc, la question, c'est de savoir si, quand les missions n'arrivent pas, comment est-ce que ces fentes sont prises en charge? Il faut que je précise quelque chose. Nous opérons les fentes. J'ai fait l'historique des fentes labio-palatines avant que Smile n'arrive au Mali, avant 2010. Mais sinon, depuis, avec le reste de mon équipe, nous opérons les fentes labio-palatines. La composante qui manque, réellement, c'est la partie liée à l'orthodontie et à l'orthophonie. Sinon, nous faisons la prise en charge holistique des fentes dans la fermeture des fentes labiales, dans la fermeture des fentes du palais. Là, il n'y a aucun souci. Donc, nous avons plusieurs chirurgiens au niveau de mon hôpital qui sont capables de faire de bonnes fermetures de fentes. Mais la question de soutien de l'État, je vais partager une réflexion avec les autres. J'ai l'impression, à écouter les uns et les autres, que c'est la coopération avec des ONG qui est toujours chose qui est la base de la collaboration avec Smile Train. Mais si d'aventure il y a des hôpitaux du secteur public qui devenaient des partenaires Smile, peut-être qu'il y aurait une pérennisation des activités si Smile Train se retirait. Mais sinon, je tenais à préciser que nous opérons les fentes sans les missions. Mais en revanche aussi, je ne sais pas si c'est la même chose au Nigeria, par exemple, qui est un grand pays de chirurgie depuis de belles années, et en Côte d'Ivoire. Souvent, quand les missions d'étrangers sont annoncées, comme les Canadiens par 2 ou 3 fois qu'ils sont venus au Mali, la population a une forte tendance à aller aussi vers ces étrangers, je dirais entre guillemets. Il y a cette forme d'attirance pour cette main-d'œuvre étrangère. Et souvent, il arrive, Madame Bankole, qu'on ne soit pas prophète chez soi. Je pense que c'est la même chose un peu partout. Et donc, mais c'est vrai que c'est un peu les mêmes réalités d'un pays à l'autre en Afrique.
Okay, Professor Banko, can you summarize that?
I will try to summarize. Well, he says that he had said that they have a center, a team of a local team in Bamako, and they operate lip and lip cleft and palates, but they don't have orthodontic and speech therapy only. And sometimes when outreach when some come from Canada or America, people sometimes prefer to go to them. I think it is because of communication. I think they do a lot of communication by media, so every people know that they will arrive. If they do communication locally, I think they will get a lot of patients too. It's
thank you very much, Dr. Adams.
Yes, thank you.
Thank you so much, Dr. Adams.
Thank you, Prof, for the opportunity to respond to what would happen if major donors like SmileTrend pulled off. As we have heard that Cleft care is largely in the hands of NGOs, and when we talk about that in our context, it's actually the support system that is largely in the hands of NGOs in terms of finances, equipment, and policies and protocols. But when you look at their strategy, actually their strategy has been to work with local professionals, and that's our experience here in Senegal. There is quite a wide variety of surgeons that regularly operate on clefts, and whether they are ENT surgeons like Professor Malik or Dr. Rudolph Job, who is a maxillofacial surgeon, or Professor Ansankale, who is a plastic surgeon. You can see that there is a variety of specialties that operate on clefts locally. Now, the support is more logistic, more financial, more in that range, and not really the technical know-how. It's more in the communication and organization and funding. So I think cleft care would continue, but maybe not at the same level of involvement because of these aspects. And this is why we would like governments to put cleft care in their budgets. We would advocate for that to be in the budget, for that to be in a regular forecast training, because those are the strengths that NGOs like SmileTrend brings to us, like training and other logistics. So I think, yeah, in a nutshell, we would still survive, but maybe not on a familiar level, on the same level that we are right now.
Thank you very much. Professor Moafo also, before I call on Professor Bankole, Professor Moafo also wants to add to the discussion on the sustainability after, if and when the funder, funder ceases to support us. Professor Moafo, please, you have the floor. You are muted. Professor Moafo is muted.
Okay. Do you hear me?
Okay, you are muted. Yes, we can hear you now. You are muted before.
Okay, thank you very much for giving me the opportunity to answer this question. It would be a very bad situation if you don't have the support of an NGO like Smitrin. We can continue the program in my country because we have the support of the Ministry of Public Health, but it's not enough. The budget.
Emily, can you help us mute? Okay, so Professor Mwafo, you can continue.
Okay, I just say that the budget of the Ministry of Public Health is very small in all our country. And you can continue the program, but we will have a lot of difficulty in terms of financial equipment and training and so on. And I think one way we need to go is we don't have in our culture to provide funds for something like this. We have many Africans who have a lot of money and they don't know what to do. And it's important to try to put this in our culture, to collect funds for cleft lip or cleft palate, or for something which is a public problem in our country, so that if Smitrin is not there, maybe locally we can have some people who can help, and we don't have a good communication to them. Maybe if when they see the picture of a child before surgery and after surgery, if you make an organization and try, because they are afraid that maybe we want to collect money to put it in our pocket, and we have to change this because it's not cultural for us. I think that is a big problem. That's what I want to say.
So thank you. Thank you very much, Professor Mwafo. Professor Bankole, you have the floor now. The questions from your hand. Thank you.
Yes, the question I have two questions in French. It's I don't see them again. Yeah. It's for Professor Traoré. She said that they don't how he can reach the patient who lived in war area. So, Professeur Traoré, c'est votre question. Il y a une dame qui demande comment vous pouvez atteindre les patients qui vivent dans les zones à haut risque où il y a la guerre. Est-ce qu'il y a des hôpitaux là-bas qui s'occupent des fentes? Est-ce qu'il y a une organisation qui s'occupe des fentes de façon gratuite là-bas, dans les régions où il y a la guerre?
Merci, madame. Oui, merci, madame Bankole. Merci de l'intérêt pour notre situation particulière. Récemment, au mois d'octobre, nous avons organisé une mission à Tombouctou, dans le nord du Mali. Mais ces missions sont tenues, on ne fait pas beaucoup de communication avant la mission, mais nous faisons plutôt des choses, on fait du recrutement par les médecins locaux. Et nous faisons la chirurgie. Récemment, nous avons opéré à l'hôpital régional de Tombouctou, mais pour des questions de sécurité, nous n'avons pas beaucoup communiqué autour. Donc, il y a eu une trentaine de cas opérés, mais toujours par l'équipe de Horizon Vert qui part de Bamako jusqu'à Mopti. Et pour des questions de sécurité, nous avons fait le reste du trajet en bateau pour arriver à Tombouctou. Donc, malheureusement, il ne peut pas y avoir de communication, parce que souvent, les djihadistes capturent le personnel de santé pendant quelques semaines pour soigner leurs blessés.
OK.
Madame Bankole, vous m'avez bien entendu?
Oui, je vous ai entendu. Je vais essayer de traduire. I will try to summarize what he said. He said they can go in the area of war, sometimes with his team to operate some patients, but we cannot do a lot of communication about it because of security. I think it's what he has said for this patient. Do you hear me? Professor Adeyemo, do you hear me? I tried to translate what...
Yes, I heard you. I heard you. Do you have any other question?
Yeah, there is one other question. I don't have the name of the person who asked this question, but she wants to know what Smitrin can do to implicate...
No, don't worry about the name. Just read the question. Let's...
to oblige the government to participate at this at the cleft lip treatment. Do you hear me? Hello.
Who is to answer the question?
Do you hear me?
La question est adressée à qui?
La question est adressée, je sais pas, à tout le monde. À tout le monde. À Smile Train. À Smile Train. Smile Train, il y a quelqu'un. Emily, you can answer this question.
I'm sorry, please take the question again.
Yeah, she wants to know what Smile Train can do to oblige every government in Africa to participate to cleft and lip treatment.
Okay, thank you for the question. We have the privilege of having NK Obi in the room. She would be able to take that question. Mama NK, are you able to respond to that?
It's a national obligation for government to take care of birth defects.
NK is still
Good
muted.
presentation. In fact, I just typing something and Emily put me on the spot. Emily, I'm going to wipe you today. Thank you. I think the role of healthcare can never be really brought up a lot of ideas on how do we. What comes to my mind is advocacy. We really need to be out there advocating at all levels of government, both at the national, at the local, at the state, and also at the regional level, on ensuring that the government really plays its role, particularly in funding and in building and strengthening our healthcare system.
You don't understand. I don't hear.
Don't hear anything. Don't hear.
Cleft care professionals within the different spaces we're in. We reach out to our government and work hand in hand with Smile Train. Smile Train is trying, but then of course it's just Smile Train. There is need for the people to see that the government considers and takes its rightful place in promoting comprehensive cleft care in our regions and in our countries. I hope I've been able to answer the question. Stimulating session.
Thank you very much, NK. Professor Bankole?
Yes?
You have any other question?
No, I don't have any other question.
Okay.
Madame Bankole? Madame
Oui.
Bankole?
Ah, vous voulez, Oui,
oui, j'avais levé la main. Moi,
oui.
je voulais, maintenant que je suis administrateur d'un hôpital, je me dis qu'une suggestion à faire à Smile Train, c'est de faire en sorte que l'ONG soit reconnue d'utilité publique pays par pays. Et ça peut aider à aller vers une reconnaissance avec la signature de convention avec chaque État. Cela peut aider à pérenniser les activités, à mon sens. Et je voulais faire cette suggestion à partir de mon expérience récente d'administrateur d'hôpital. Et là, les États africains seront plus enclins s'ils délivrent à Smile Train le statut de structure d'utilité publique par pays.
Oui.
Donc, je ne sais pas dans les autres pays comment ça marche, mais au Mali, cela pourrait aider à donner une plus grande assise encore à Smile Train. C'est une suggestion que je fais pour Madame Obi, Monsieur Beckett. Voilà.
Oui. Hello. Merci beaucoup, professeur Traoré. Monsieur Beckett, vous êtes en ligne, vous avez entendu ce qu'il a dit? Monsieur Beckett? Monsieur Beckett? OK. Alors, vous pouvez traduire parce qu'il faut qu'on ait des conventions avec nos États pour dire, les ONG, pour dire que c'est voilà, c'est d'utilité publique, que nos organisations sont d'utilité publique.
Professor Amadi, as an administrator in Mali, in the hospital in Mali, is just doing a suggestion. He wants Smile Train to be in each country, and if Smile Train is recognized in each country, this can help Smile Train to be taken by the government.
To sign with the government.
Okay.
That is public utility. What each ONG do is public utility. I know. But we need to sign with each government for that. Do you understand what I say? Madame Obi?
Yes. Yes, Professor Pankole.
Okay.
Okay. Emily, are you there?
Emily?
Yes, I am, Beckett. I am here.
Okay, Beckett. Okay, are you there?
Yes, Prof.
Okay, so I think essentially the last discussion was about the need to have an MOU with each government in Africa, if it is possible. And this one is actually directed to NK, and I know that they are doing that. I know from the experience that we have in Nigeria. And also, I must also let us know that one of the ways to convince any government anywhere in the world, particularly in Africa, is statistics. And I'm aware that in Nigeria, because we need to know the burden of the body. Once the government is able to see, I sincerely hope that that is going to encourage. So I'm aware that we are doing that in Nigeria. I want to know how common the cleft plate in Nigeria, and we're doing that. And I guess that the number, by the time the government sees the number, they will respond. The truth of the matter is that if you look at other care, you know that for me, I'm looking at a situation in which cleft care is going to be elevated to the point that you know that in many parts of Africa, like example in Nigeria, we have a specialized hospital for eye, for orthopedics, for ophthalmology like eye and ENT. Also, we have a specialized children's hospital. And I think by the time we are able to get the data, we may be able to push the government in all the African countries to have a specialized care. You can call it cleft and palate hospital or craniofacial defect hospital or something like that. And before we are able to achieve that, we need data. We need to know the body. And I think Smile Train is doing that to the best of ability. And that I know in Nigeria.
It's true, Professor Adeyemo.
Thank you very much.
Okay. So I think now we need to round off. Professor Pankole, can we round off? Beckett, can we round off now?
Beckett, Monsieur Beckett? There is another question, is the convention with the government, the move with the government. Have all ONG have a move with each government in Africa? I think it is an important question because when there is no convention, there is no move, we have to pay for the government for the importation of all donations we receive from Smile Train. Monsieur Beckett? I don't hear Beckett now. what we have to do, Professor Adeyemo?
Okay, I like
Professor Adeyemo?
Yes, I can hear.
What is it?
I can hear you. Can you hear me? Professor Bankole,
Yeah,
can you hear me?
I hear you.
Yes, I can hear you.
Yes, I hear you.
Okay, so if we have no more questions and comments, can we go ahead and round up the program?
Okay, great. Thank you so much, Professor Adeyemo, Professor Bankole, for the patience and the translation. Thank you so much to all our moderators. Once again, we celebrate a whole year of having brought you the Telecleft virtual lectures, thanks to our partnership as SmileTrain with the West African College of Surgeons. At this stage, I would love to welcome Professor Debola to give us a word or two to also celebrate this incredible milestone. Professor Debola, over to you.
Thank you very much, Emily. To all attendees, I want to thank you that we look back and it's 1 year. We started this Telecleft series 27th of April 2020, and today is 26th of April, so which makes it 1 year exactly. And it's really something that was started as an experiment. In every bad thing, there's always a good silver lining behind it. Now, due to the initiative of SmileTrain through NK and the African Regional Director, Dr. Esther, we partner with West African College of Surgeons and the SG, Professor Shvela, cooperated, and this is what has translated to this. Now we have, within 1 year, we have 4 series. Telecleft 1, Series 1, 2, 3, and 4. This is the 4th series we're having. We have a total attendance registration of more than 2,000 registrants, and we have an average monthly attendance of 1,897. And for every session, we have an average attendance of 130. So this has been a great thing. COVID has opened up, physical barriers has been broken, and this has been an amazing journey so far. And I'm very privileged to be the West African coordinator to anchor this. And I really want to seize this opportunity to thank all the attendees, because without the attendees, this would not have happened. And it's not just a West African thing, it's not a Nigerian thing. It's not only an African thing, it's not a global platform. It has given us the opportunity to showcase what we can do. Because all the participants that are the presenters, the facilitators, the moderators have been African Cleft providers. And this has given us an opportunity to network also. So we are looking forward to another 1 year. We don't know where we are going to go to. Maybe this will even become an institution, a virtual institution, we don't know. But really, I want to give kudos to the originator, that is SmileTrain and West Africa, and especially acknowledge the role of NK and Esther and the Secretary General of West African College of Surgeons, and all the SmileTrain team that has been behind the scene facilitating this, Nicole, Nina, Emily, Victoria, all the people, Beckett, that have made this to happen, doing the translations, doing everything. Despite the challenge of internet, we are still sustaining this. And we hope that it can be something that is sustainable. And as I've said, we hope that when we are celebrating the 2nd year, we're having an institute that is a virtual institute that is also supporting comprehensive care. So once again, I want to thank everybody for being part of this journey and this success story, and wish that we continue to keep in faith and continue to participate. Thank you very much.